Professor Hussein, of course, for this very nice. I think the suprarenal gland was always not the very common subject to talk about in EUS meetings, but I think thanks to your lecture, you have pointed and made a very good spot about this problem that, of course, any endosonographer might meet or patients might be referred to you. And I am really glad that I have attended this lecture with you because it was very, very informative. You may excuse me to start to direct the question to the professors according to their presentations, if you allow me. So the first question is for Professor Anna from the celiac plexus lecture. Professor Anna, are you with us?
Yeah.
So there was still remaining few questions for you, sir, madam. The first question was, do you think that celiac plexus block is associated with increased mortality? Did you notice that in your patients?
Do you think about block or neurolysis? Because the question is about block. It's different than
yes,
neurolysis.
but you might answer the same question for both techniques.
Yeah, in my when it comes to my experience, I performed block only for chronic pancreatitis, and it was rather a safe procedure without any dangerous. Yes, there are written cases only about the dangerous blockade with alcohol in chronic pancreatitis in many cases of this procedure. Yes. If it was performed about 10 times this kind of procedure with necrosis of this area and gastric wall. Rather, this method in celiac plexus neurolysis and block is safe. When we look at the vessels where we are so close to them, that the complications are very rare. Probably even if we put the needle maybe close to the wall of the artery of celiac trunk, it's not dangerous. Yes, so yes. To be honest, I recommend this method. Maybe the efficacy is not so high, but the safety is definitely wide.
Yeah. Okay, there is a question from Kosovo. Okay. About your preference in practice between neurolysis and the block. And the second question from the same doctor from Kosovo is about the risk of damaging the celiac trunk by alcohol.
As I mentioned before, that the risk of damage is rather low. As there is written that the serious complications are lower than 1%. So it's only minority when it comes to the complication. I must tell you that I performed many these procedures. I think that above 100, and I've never had any serious complications, yes. Okay, so according to the papers, according to the studies, meta-analysis, it's rather safe procedures when it is performing precisely and without. I don't know, I would like to ask Professor, what's your opinion? But in my center, to be honest, I was afraid in the first cases when I performed this method because it looks so dangerous, but it isn't.
Thank you for your answer. Actually, in our series in Cairo University, and I think in also Asyut University, and in I think Sharia University, there is no serious complications, but I'd like to highlight that there are two cases of major complications, one from Canada, Montreal, by Anand Sahai, and he mentioned it several times in the congresses, that there is extensive thrombosis of the, I think, main branches of the celiac artery, extensive thrombosis and extensive necrosis of the thrombosed arteries, and the patient finally died of this complication. And another one from, I think, Turkey reported paraplegia due to anterior spinal artery spreading of alcohol. But these only two cases in thousands of cases of celiac plexus neurolysis.
Yeah, yeah.
So,
And
but
they
when
were
these two cases happened, some refrains to do alcohol, celiac plexus neurolysis by alcohol. But I think now they are doing it freely without any precautions. But at a time with these two complications, some advise not doing celiac plexus neurolysis and only celiac plexus block. But now I think all the world are doing celiac plexus, and even Anand Sahai are doing a very large number. He is, I think, the most famous one, doing a horrible number of
Yeah,
cases, because
yeah,
this is the
definitely.
only these are the only two cases of reported complications.
I found more, about 8 cases with empyema, with abscessus, with necrosis, but these are only not more than 10 cases in the
Yes,
world
yes,
doing for above 20 years this kind of procedure.
and thousands of cases. Yes.
yes.
Yeah.
Okay. The next question for Professor Hussein about the radio frequency. There is a question from Dr. Tariq about the use of radio frequency ablation in pain management of pancreatic ductal adenocarcinoma.
Yes, it is used. It's used as pain
Yes.
management in pancreatic duct adenocarcinoma.
Okay.
Even Anand Sahai in Montreal, in Canada, are doing celiac plexus neurolysis if he find pancreatic head mass. He is doing celiac plexus neurolysis in the same setting, even if the patient has no pain. Something very strange. And
No. Dr. Hussein, the question
yes.
is about destroying it by radio frequency ablation, not by the alcohol, not
Not radio frequency, not celiac.
using radio frequency ablation in pain management of pancreatic
Yes, yes,
carcinoma.
yes. I didn't do it before. I didn't do it before. And if you endosonographer do it, very rare. No considerable series to judge its efficacy with celiac plexus neurolysis, but some endosonographer are doing it. And Dr. Zahir Houmani from Lebanon did his first case of celiac plexus neurolysis, and they are telling that it is very effective. It is
By radio
more
frequency ablation.
more
By radio
radio
frequency
frequency
ablation
ablation is more effective than
than an
celiac
alcohol.
plexus neurolysis, but small number of cases cannot judge the real life. I think Dr. Anna mentioned that in celiac plexus neurolysis, mentioned radio frequency ablation. Here in Egypt, we didn't do it, of course, for financial
Me
problem.
too.
The needle of radio frequency ablation is very expensive, very expensive, while the alcohol is very cheap. So I didn't do it before. I wonder if Dr. Anna has an experience about
Me
this
too. Me too. I
aspect.
don't have any experience, only from papers, yes?
Yes.
Yes.
They are just scattered cases, I think. Okay,
Yeah.
next question for you, Dr. Hussein, as well, from our dear colleague Ahmed El-Miligi. And may I use this question to congratulate him for getting his MD degree just a few days ago. He's a very promising young endoscopist from our unit, Ahmed El-Miligi. Inshallah, he will become a very good and promising doctor in the just coming in future. His question for you is about the size limitation for applying radio frequency to adequately ablate the pancreatic lesion. Not only using it, but to adequately ablate the lesion. What is the maximum size limit for adequate ablation of a pancreatic lesion?
Yes, there is no maximal limit, but it depends on would you apply it for radical cure or for just palliation? If
I
you
think
apply
his
it for
question is
radical,
about cure because he
yes,
said
about cure,
ablate.
then 2 centimeter.
Okay.
2 centimeter. But if you have a large, especially neuroendocrine tumors, if you have a larger tumor, you can apply it 2 or 3 or 4 at sites. You can do it in the bottom of the lesion, and then withdraw the needle to do it in the upper aspect of the tumor, and then to the right side of the tumor, and then to the left side. You can apply it more than once. But in experience of Mark Partey, he applied to the neuroendocrine tumor 1 to 2 centimeter, or more than 2 centimeter if the patient is surgically unfit. So you can apply it from 1 to 2 centimeter. You can apply it more than 2 centimeter, but you should apply, if the tumor is larger than 2 centimeter, you should apply more than one application. It's the same session. Or moving shot technique. Regarding the cyst, you should aspirate all the fluid of the
First,
cyst.
before.
It should not more than 1 centimeter. If the cyst is 3 or 4 or 5 centimeter, then you aspirate the whole fluid in the cyst. The cyst should, after evacuation, the cyst should not be more than 1 centimeter, and then start to do radiofrequency ablation. But at the first, you apply it to the inoperable tumor. And the inoperable tumor, of course, it may be 3 centimeter or 4 centimeter or 5 centimeter, but this is for palliative purposes, and you can apply it in multi-shot technique, more than one side of the tumor. But if you aiming at radical cure, especially in net, I think the most suitable size is less than 2 centimeters.
Okay, thank you, Dr. Hussein. So there is another comment from Dr. Tariq about he's mentioning that there is a group in Thailand by Professor Brother Mashai with good results in pain management of using the radio frequency ablation in pancreatic ductal adenocarcinoma, and he says that they presented in their work in the EUS days, the last EUS days, which was conducted in Thailand just the last year. So I think this was the source of his question for you. Okay.
Yes, thank you. Very, very nice knowledge. Yes.
Yeah. The next question for Dr. Katarzina. Are you there, Dr. Katarzina? I think.
Dr. Anna will answer
Okay,
instead.
Okay, she will answer. Okay. The question also again from. Yeah, she's on duty. Yeah, maybe she's doing something. So the next question. Dr. Ahmed El-Miligi about can varicose coiling provide good alternative to tips in cases of very large fundal varices? I mean, his question about large fundal varices. Would it replace tips? Would it be a replacement for tips for such cases?
When we are talking about criteria of inclusion to the treatment with coil, is definitely this what we are able to find in the stomach. Yes, we don't say now about the patient, about the reason of this. Very often we have the main reason for the, also not only in secondary prophylaxis but also with primary prophylaxis, is very important. That primary prophylaxis, secondary prophylaxis, and during acute bleeding, we can use coil treatment. And it doesn't matter with the tips, yes? So the decision should to be taken, do we have any inclusion, do we have suggestion, for example, waiting for the tips, we are able to perform this kind of treatment, sometimes save the life of the patient.
I think the question is, would this replace that? I mean, if there is availability of doing the coil and cyanoacrylate, does this stop our need or eliminates the need for performing tips, or it could be just another alternative?
It's difficult to say because there aren't these papers and you know, but it is similar as during the treatment of the varices by endoscopic methods. When we use cyanoacryl only, in endoscopy, yes, because the results sometimes are comparable, but definitely one session very often using coil and this concomitant treatment with the cyanoacryl. So sometimes only one session, not so many as during endoscopy, we have better control on the treatment. We see immediately the results of the treatment. But when we are talking about tips and qualification for this kind of treatment, that this treatment by EUS is similar and comparable with endoscopy treatment, but different method, yes, different technique.
Yeah. Well, of course, you are oriented about the recent trials of performing the tips by the US guidance itself. So maybe later the patient will come to you, perform EOS, and you choose whatever technique you want to do.
The future,
Okay,
the
thank you for
expansion of US.
Yeah. Okay, so the next question again about the coil, about the how long will you wait before feeding the patient after applying the coil and the cyanoacrylate?
Yes, so we perform the procedure. On the end of procedure, we check in the Doppler, do we have completely stopped and we don't have any Doppler signal from the varices. So this moment is the end of the procedure. Sometimes we have to divide this and we don't end the procedure to the end. So we have the signal, for example, in the part, but we should wait few minutes, sometimes 5-10 minutes, because it's not immediately, yes? But when we check the effect of procedure next day, it's much more advanced than immediately after procedure, yes? So in our hospital, we perform procedure with sedation. We perform this including with in placing sometimes few coils with few places of cyanoacryl, and next day we check in endoscopy or EUS the effect of this treatment. We check is there any bleeding, and the next after the next day the patient is ready to come back home.
Okay, so you don't.
Excuse me.
So you don't feed the patient until the second day check. So you keep the patient this day on parenteral nutrition until the next day for the second look before allowing the patient to be discharged home or resume his oral feeding.
After the procedure, we check with endoscopy view, do we have any bleeding or
not?
Any
bleeding, of course,
and if we don't have any bleeding, if we don't see any complication, the patient is able to drink water, yes, but without feeding.
And
so next day, when we do the procedure in endoscopy, the patient is ready for consuming the meals.
Okay, so to simplify it, after performing the procedure, you will check by the Doppler that there is no signal, and you will check by the endoscopy that there is no bleeding. You will not allow the patient to eat, but you might allow him for small amounts of water intake. Instead, you will replace that by parenteral nutrition. Next day, you will recheck the patient again for Doppler flow and the obliteration of the varices and no bleeding. After that, you discharge the patient home and he can start oral feeding. Is that correct?
Yes, exactly. Okay. In my opinion, this concomitant treatment with coil and cyanoacryl and glue is more safe, because there are papers about only inputting the coil.
The coil, yes.
But sometimes they were observing the bleeding after the coil only. Because, you know, when we connect this kind of treatment, the first step as the coil and the second as a glue, that this moment we have much more safer method of the treatment, in my opinion, also, not only in the papers. Okay. So to be honest, we performed, I don't know, Katarzyna is writing this paper about these patients, but because we sent, it will be the second paper, but it is about above 30 patients with this coil treatment, and we never had any severe complications. Bleeding, but not severe, without any necessity for much more intervention.
Okay, thank you, Professor. Okay, the next question is for Dr. Rasha. About Dr. Rasha, are you with me? Dr. Rasha?
Dr. Muhammad? Yes, I am with you, Dr. Muhammad.
Okay. The question for you from Dr. Yassin about how can you differentiate local hypoechoic pancreas in chronic pancreatitis from a mass?
Local hypoechoic.
Yes, in chronic pancreatitis from a mass.
Okay. First of all, local focal lesion of chronic pancreatitis, we can find it in autoimmune pancreatitis. If it is a localized mass,
Yes.
we also, this is compared with type 2, there is a seronegative IgG. Also, we cannot find any affection of the vessels or compressing effect. And patient will have a history of vague symptoms like epigastric pain, abdominal pain of long duration. Okay, and also it may be associated with other autoimmune disease.
Yes.
Okay,
Yeah. Comment. Okay.
Dr. Hussein?
You want to comment?
I think he is me asking what is the difference in the endoscopic endosonographic picture.
Yes.
The ventral dorsal pancreas, the ventral and dorsal pancreas has a constant anatomical relation. If you are looking from the duodenum, from the second part of the duodenum, you will find the hypoechoic ventral to the left side of the screen and the hyperechoic dorsal to the right side of the screen. If you are examining from the stomach, from station 4, from the venous confluence, then you will find the hypoechoic ventral pancreas in the bottom of the screen, in the most distal part of the screen, and the hyperechoic is above.
Yes.
So there is a classic anatomical location of the ventral and dorsal pancreas. Second, the dorsal ventricular pancreas has a sharp line of demarcation, very sharp line, exactly like the areas of focal depletion and focal deposition in the liver. They have a sharp line. If it is a mass or nodule or something like that, the border is rather
hazy and irregular.
Rounded, or difference is that the ventral pancreas harbors the common bile duct and the pancreatic duct at the region of the papilla. So the CBD and pancreatic duct runs in the ventral part, in the hypoechoic ventral part of the pancreas, and they are running very well, very smooth, not interrupted, no dilatation, as if it is a normal common bile duct and pancreatic duct. So don't miss it, or don't mistake it for mass, because it has a classic location in the duodenum, and while examining from the duodenum, and the classic location while examining from the stomach, they have sharp border of demarcation. Vessels and ducts, as you said, as Dr. Rasha said, runs very nicely without any interruption. So if you put it in your mind, you will not mistake it for a malignant mass or even a benign mass.
Okay. So the next question from Dr. Wael Shal, he's saying, in case of incidentaloma or suprarenal lesion, how to rule out pheochromocytoma if we are going to do fine needle aspiration? Should we have to first do if hormonal assay is normal? How safe is FNA in case of unclear lesions? So I think these are two questions. First question, in case of incidentaloma or suprarenal lesion, how we can rule out being pheochromocytoma. And the second question is how safe the fine needle aspiration in case of unclear lesions if hormonal assay is normal.
Yes, it's a very nice question, but the answer is straightforward and clear. If you find incidentaloma, you don't need to do FNE at all. Okay? If you find an incidentaloma, benign looking, and no primary tumors, no primary adenocarcinoma, no primary lung, you are doing it for something else, and you
Yes.
accidentally find this mass and having the benign criteria. So no need for FNA at all. But if the mass has a malignant criteria or there is a primary tumor, then you should do FNA. If you did FNA in the presence of primary tumor, so it is mostly will be a metastasis and not a pheochromocytoma. So there is no prerequisite to do hormonal assay before doing FNA, except if you are suspecting a pheochromocytoma. If the
Yes.
patient clinically has paroxysmal attacks of hypertension, if he did a lab findings before and hydroxyindole acetic acid is high, if you are suspecting pheochromocytoma and you find a suprarenal mass, then here you should suspect pheochromocytoma. And to my mind, I think FNA is not dangerous at all. FNA, but don't do FNB because FNB is somewhat traumatizing than FNA. I can use 25G FNA needle if I am suspecting pheochromocytoma. But in most instances, the suprarenal masses you find during US examination are incidentaloma, and incidentaloma more than 90% are non-functioning. The patient is not complaining of paroxysmal attacks of hypertension, so the diagnosis of pheochromocytoma is very far away. But if you are suspecting pheochromocytoma, I think doing FNA with 25 needles will be non-traumatizing. I didn't do FNA for a suspected cases of pheochromocytoma. But most of instances who are doing FNA, the situation is not that of pheochromocytoma at all. If it is an incidentaloma, then the patient is not complaining, no paroxysmal attacks of hypertension. So it is not mostly it is not a pheochromocytoma. If you find it in the presence of primary malignant tumor, then it mostly it up to 50% it will be a metastasis and not pheochromocytoma.
Yeah.
So I think there is no any paper or article or any recommendation to do hormonal profile before doing FNA of a suprarenal mass.
Okay.
But if you
Thank
are suspecting, you can do it FNA by 25G needle.
Okay. So the next question, any feedback about radiofrequency ablation in cholangiocarcinoma?
This is ERLA, not EUS guided radiofrequency ablation. This is endoluminal left of frequency endoluminal radiofrequency ablation, and really I didn't do it before. It is a palliative maneuver, palliative, and for keeping patency of the CBD by burning a large part of the cholangiocarcinoma, whether proximal or distal. But really I don't know much about that because I didn't it before. I wonder if Dr. Anna or Dr. Katarzina did endoluminal radiofrequency ablation for cholangiocarcinoma. I have no experience with that because it is not EUS guided. It is done during duodenoscope. I didn't do it before, and I have no much experience in that point. Do you have some information about Dr. Anna?
Dr. Anna?
Unfortunately, we didn't perform this kind of procedure yet. We are preparing, but not yet. I don't have any my own experience.
Okay. So what about the experience of radiofrequency ablation in mucinous pancreatic cyst? From Dr. Ayman Kawasmi.
In series of Mark Partey and Mark Giovannini, they did ablation of 16 cases of IPMN, intraductal papillary mucinous neoplasm, which is at the end, it is a variant of mucinous tumor. It is a mucinous neoplasm, intraductal papillary mucinous neoplasm in 16 cases. And as I mentioned, the success rate is 69%, about 70%. But in mucinous cystic neoplasm, in their series, all the cases are intraductal papillary mucinous neoplasia, not the classic mucinous cystic tumors. And as I mentioned, I did 3 cases of solid adenocarcinoma and insulinoma. I think no other papers mentioning mucinous cystic neoplasm. A paper of Mark Partey and Mark
IPM.
Giovannini was done on intraductal
IPM.
mucinous. But I think what is applied on intraductal mucinous
Could be.
IPMN will be applied to mucinous neoplasm, but you should aspirate most of the cyst fluid to decrease the size of the cyst to less than 1 centimeter. This may be difficult because in aggressive
Very difficult, yes.
cases of mucinous cystic neoplasm, the mucin is very viscid.
It's viscid. It
2
blocks
days
the
ago, 2 days ago, I faced a case of mucinous cystic neoplasm, very viscid mucin, very difficult, very difficult. Just I aspirated about 5 cc with 19G needle, only 5 cc from cyst about 6 by 7 centimeters. So, but if that fluid can be aspirated, I think you can apply radiofrequency ablation exactly as intraductal papillary mucinous neoplasm.
Yeah, thank you, Dr. Hussein. I think now we have reached the end of questions. There is only one remaining question to Dr. Siola and Mr. Ahmed about would be any recording for such valuable lectures and such valuable course. Of course, all the attendees are conducting their extreme appreciation for the whole team, Dr. Hussein, Dr. Anna, Dr. Katarzina, and of course, all the respectable speakers and members of such an elegant course. So, Dr. Siola, would be any recordings for this course?
Of course, doctor, of course, it's will available soon, inshallah.
Okay, so
there are two types. There are 2 types, Naguib, of recordings. The whole day is recorded with the active link in our Facebook group. Go to our Facebook group. You will find the live transmission.
It's live now. Yes.
Yes, it is now live. After the end of the session, the icon will be there, and you can see the day from the first minute to the last minute. But after that, within few days, Utopia, Dr. Siola promised that we will upload the 19 lecture of the 4 days separately on our YouTube channel of our unit, and we will provide the active link on our Facebook group, so you can specifically to any lecture you want, and you can see it all successively, or you can go to any lecture you want. So there are 2 kinds of uploading, one available now in our Facebook group, and the other will be within few days in our GHEPCA, Gastroenterology Unit of Cairo University Internal Medicine Department, and the active link will be provided, and also the certificate will be provided after a while by Dr. Siola, and will mention the way to get the certificate in our Facebook group. Finally, I'd like to thank you all. To thank you first to the audience, people who are interested in endoscopic ultrasound. I hope that they are enjoyed the course, the 4 days of the course, and the whole course will be uploaded in our YouTube channel and Facebook group. You can go to it anytime. Anyone wants to start his journey with AUS examination or AUS career, he can go to see the whole 19 lectures. Thank you very much for the speakers in the 4 days, and special thanks to our colleagues from outside Egypt, Dr. Anna Kozowska. I am believe.
We will practice pronouncing it. We promise. We will practice.
Yes, but generally, I believe that difficult names are behind great personalities. So thank you, Dr. Anna, and thank you, Dr. Katarzina, and thank you, Dr. Mohammed Abdel Hafiz from Munich, Germany, in the yesterday. Very informative lectures, and thanks to all our colleagues in Egypt, speakers and commentators. And thanks to Utopia Pharmaceutical Companies, that did a lot of work in organizing this course.
It's my
And
pleasure, Dr. Hassan. Thank
we
you.
have a promise that as soon as I can, the 19 lectures will be provided with very high quality in our YouTube channel and Facebook group.
It will
Promise, Dr.
this
Ziola. I
yeah.
told you several times, but this is the last time. Within few days, we should
It is
we should have
available
the
this week,
lectures in the
inshallah.
YouTube. I will not tell you again.
Okay,
Okay.
doctor, of course.
Then thank you very much for all, and thanks for the our audience. I hope that we produced a useful thing to those who are interested in endoscopic ultrasound. Anyone wants to have a comment? Most welcome.
Congratulations, Professor, for this excellent congress by internet, by air. And thank you for the possibility of participation. Thanks a lot, and I hope we will meet in the real congress in the live. Thank you very much.
Of course. Of course, and all our colleagues in Poland. Now I know Dr. Anna, Dr. Katarzina, and Dr. Michel Zorniak, but he's now in Germany. So we have a lot of friends in Poland. And lastly, I would like to announce our second EUS Egypt. It will be a virtual congress next Friday, 3 p.m. Cairo local time, Greenwich +2. Will be with us Professor Mark Giovannini, of course. We all know Professor Mark Giovannini, one of the most famous endosonographists worldwide. Dr. Hakan Sintork from Istanbul, Turkey, and Dr. Muhammad Osman from Baylor, Texas, Houston, United States, and Dr. Kalpesh Patel in the same unit with Dr. Muhammad Osman. There will be very nice subjects from international figures, and Dr. Ahmed Murad and me will have another 2 lectures. The schedule will be soon, today or tomorrow morning, on our Facebook group, and this will be the end of the activity of EUS, and hoping after that we can see our nice lectures in the YouTube channels, inshallah. Thank you again, Dr. Anna. Thank you again, Dr. Katarzina. Thanks to Dr. Mohammed Naguib. Thanks to Dr. Rasha, and thanks to Dr. Wael Abbas, the speakers and the commentators of today. And we will continue, we will continue communications on our Facebook group with the nice cases of our dear colleagues sharing in the group. And thank you very much. And I think we reached the end, and hoping to see you always.
Inshallah.
شكرا.
Thank you.
السلام عليكم.
مع السلامة.